positive and who need hospitalization. You may have also heard both yesterday and a bit more today about a new monoclonal antibody drug, which is becoming available, at least in small quantities. Yesterday, the FDA approved a monoclonal drug by Eli Lilly, which is administered by IV to patients who have, I don't want to say significant, but they are moderate symptoms, but do not require hospitalization, but are otherwise in a high risk group. So that would be elderly or folks with underlying health conditions. And both President Trump and Governor Christie received this drug a month or so ago when they both tested positive, and as you saw, they both came through that experience in good shape. There's a second drug being produced by Regeneron. So both of these drugs should be available, at least in small quantities. I know the FDA has purchased, they say, 300,000 vials of the Eli Lilly antibody drug for 300.
Part of that will be the introduction of what HAIO is in our structure. We also have the list of who's participated. It's great to see it growing. And our agenda today is the first session is going to be the patient room of the future, which I mentioned at the beginning is kind of bringing us back to our roots. And then it's going to be followed by Stan talking with a great panel on the mechanical systems of the future. So the panelists are John Meservey for the session one, David Burson, Sandra Muse, Andrew Grumback, Patricia Nobre, and Teresa Wilson, and I'm going to be moderating this session. So just to start out, in 2015, there was a competition and a series of work sessions that resulted in doing a test room at Brigham and Women's Hospital. So we're going to be talking about that first, and then we're going to follow up with our current work at Newton Wellesley Hospital. So John, I don't know if you want to talk about the beginning of the competition, or if you'd like me to cover that.
No, I can say a few words, Teresa. We were challenged by Peter Slavin, who's the CEO at Mass General, to take this on and to make a difference in terms of the environment of care, which I know is a loaded term, but the environment of care in terms of architecture in the inpatient environment, with an aim to reducing hospital-acquired infections. And actually, initially, Peter offered a room at Mass General as our initial prototype room, or to build our prototype room. Unfortunately, by the time we got organized to design and ready to construct, that room was no longer available, and so it took us a little while to find another one, which took us to the Brigham. But we have had the ongoing participation of the head of infection control at Mass General, and as we've moved to other hospitals, we've had the heads of infection control at the Brigham and at Newton Wellesley involved as well. And while the intent was to be able to produce a white paper associated with before and after testing to document the benefits of some of the modifications we made in the design of the room. Unfortunately, we haven't been able to do that yet. We're hoping that Newton Wellesley will provide some opportunity, although it's probably going to focus more on cleaning, the ability to thoroughly clean the room, just because we will only have one prototype room at Newton Wellesley until an entire floor, for instance, is rebuilt. But nevertheless, I think important information will come out of this work, and the infection control folks are side by side with us, and Paula Wright, who many of you may know from Mass General, although she's retired, she continues to be involved in this work with us. So we've got a great set of resources, and we've got some tremendous collaboration going on, which is a result of the competition that we sponsored back in 2015, out of which came a ton of ideas. I guess that's what you're going to talk about next. Is that correct,
Yep.
Teresa?
Yep.
Yeah. Okay.
So there was competition, and with 7 architectural firms, and I'm just showing a little clips of each of the people who competed. But the bigger picture is each group had some really interesting concepts that we looked at as we moved through the process. And there was no winner, as John said. What was asked is that we form a working group, work collaboratively together to help further the process of reducing HAIOs in our room. Some of the concepts that came out, and facilitating room cleaning, and again, this will be available for you, but these were all brought up in the competition winners, and they were used to analyze the results in a very well attended BSA meeting. And from that point, we ended up forming the working group. And as John said at the very beginning, Paula Wright and other infection control preventatives were really important to just kind of giving us the basics on what we need to look at, and then looking at targeting the evaluation for the criteria. What's been really wonderful is the information is non-proprietary. Everybody's gone out to the world and shared this information, and also shared it within their offices. So it's been an extremely worthwhile process, and very exciting to capture the passion of people working in healthcare to share their information freely. So Andrew, if you want to talk a little bit about the process of when we moved into working on the room at Brigham and Women's.
Yep.
Just before Andrew jumps in, Teresa, you shouldn't be shy about highlighting the paper you wrote on the. Why don't you go back a slide?
Okay.
Yeah, there you go.
So the result of one of the conferences we did, and I see many of the people who were there with me, was that FGI attended a conference and asked us, they were really interested in the process of how we did that, which was, I think, as equally important, not as equally, but as a critically important part of how we collaborated. And they asked me to document how that happened. So that was a pretty intense process, and the result is a white paper through FGI that can be accessed in the link at the bottom of the paper. And it really focuses on the wonderful collaboration and what we were looking at a little bit more intently than what you see in this presentation. But it's you can click the link when you get the presentation later on. There you go, Andrew.
All right, thanks, Teresa. So luckily, when we were starting these discussions after the competition, we had the opportunity that a project at Brigham and Women's Hospital that Smith Group was working on was about to start, and Brigham and Women's was willing to have this this unit be sort of somewhat of a test unit for many of these concepts. So this was a bone marrow transplant unit that we were doing. It was one of a series of units that we had been working on. So we had developed a prototype and kind of improved on them moving through. So this was the 4th unit that we had done in the Brigham Tower. So we were kind of working off a really solid base that then we could improve on for this. So this document is an A3 sort of knowledge brief of some of the information that we had as a group been accumulating, kind of looking at different technology, different information. So really in 1 or 2 page documents, really summarizing some of the concepts that we thought were worth pursuing moving into the development of the rooms at Brigham. Next slide.
What happened during the working sessions, we would evaluate products. The group was actually working there. They pulled this document together.
So the unit we were working in was a 10-bed bone marrow transplant unit. So as you can see, it has kind of a unique floor plan. The Brigham Tower is probably not the ideal place to be doing the new kind of grand design in a way, because it is much smaller than you would typically see, because it is a 1980s unit, 1980s building. So But we did have this model where we were able to get this, where the things we were able to pursue it, design gave us some opportunities to distribute some of our ideas in more than just one room, but it also posed some challenges as the hospital wasn't necessarily comfortable with experimenting with certain technologies and things, or putting something in just one room when they needed functional. Some of the things that we did do were really focus on making this room as cleanable as possible and making the design as simple as possible. So removing horizontal surfaces. In previous versions of these designs, we had things like card shelves and other kind of different surfaces that we were able to remove or simplify. We modified the head wall so that it went all the way up to the ceiling, so that there weren't any shell kind of horizontal surfaces up the top to be a dust collector. We used things, some of the things were already in there, such as the cove base, because it was a bone marrow transplant unit. So we had benefits of this room already being pretty highly designed for reducing infection. The room that was the primary room we focused on was actually both a protective environment room and an airborne isolation room. So it had an ante-room in it. And you can see the sliding doors there for the ante-room. Some of the things we were able to work through were a hand wave control for that sliding door. We disengaged the sink from the work counter so that we could reduce as you can see, they're fairly close to each other. Kind of simple work surfaces, knowing that as through discussions we had, kind of eliminating all work surfaces was problematic, because then people would use things like the bedside table or the patient bed for supplies. So we made sure that we still had dedicated work surfaces, but they were separated from other zones and very easy to clean and simplify.
Teresa, I just want to make sure we have time for the current. Thanks.
So occupancy feedback, I think a lot of this is related to what Andrew was talking about in terms of the type of the size and the shape of the space. And so this is all great information. I encourage you to look at it when you get the presentation. We're going to move on to Newton Wells, excuse me, sorry. So we did do a continuous improvement and plus delta. And a lot of the things on the delta in terms of incorporating technology, mock-ups, user meetings, were things that we fed forward to Newton Wellesley Hospital. And as an important note, one of the first things this group did when we reconvened in 2019 was tour the Brigham and Women's Hospital room. So Patricia, if you're on the line, if you want to just start us off on how we began.
So I think really leveraging a lot of the findings from that previous experience. And I think one of the deltas was really seeing what are the voices that we hadn't heard and how could they help inform a design that ultimately would mitigate the spread of the infections, but really looking at these ideas, how do you also at the same time look at the experience of delivering care, ease of cleaning, and the patient experience. So kind of bringing all these elements together. So what we did was a series of user group focus groups. So we did it with infectious disease folks, we did it with environmental services, and we did it with providers. Then we moved on and had them kind of walk us through the space. And that was really informative to really understand what's the order in which you clean, where are the obstacles here, and just having those kind of narrated walkthrough from a provider standpoint, but also from an environmental services piece. And then we supplemented that with the survey piece. And the survey really helped us look at a broader number of environmental service providers and healthcare providers and tell us a little bit about what are the pinch points, what are the things that are not working so well or that are working for kind of big bucket things emerge in terms of what are the things we should be really looking to tackle. So I think growing on all the previous experience that Andrew just walked through and saying what are the additional things that we should really be focused on and looking at how do we continue to tackle those. So a lot of things around accessibility, flow, people having to go in and out of the room to pick up something to fill in and really start informing the design.
And I think Sandy's on the phone now. Sandy, if you want to jump into this is where we are right now. We weren't able to implement in the first Brigham and Women's project because of the size shape of the room and throughs and
Teresa,
the design
could you
process.
introduce Sandy? And
Oh, I'm sorry, Sandy.
We've got about 3 minutes left. Yeah.
Sandy, are you on the line?
I am. Certainly, I could introduce myself just to save some
Thanks.
time. Good morning, everybody. It's a pleasure to be on this call. My name is Sandy Muse. I'm the Associate Chief Nurse over at Newton Wellesley Hospital, who has the pleasure to work with this amazing group on this collective design. I want to say that, you know, this work started in 2019. This project started. It was obviously put on hold due to the COVID surge that we all experienced in the springtime. And we couldn't have found a better time to bring this amazing group together and these minds to really think about what we can do to prevent the spread of infection. There's no better time than during this time of pandemic. So I'd just like to give a shout out to this group that I've been working with. They are just such an amazing group of people that have ideas and concepts and ideas around workflow design that has just really been amazing to work with. So I want to thank you all for that. But getting into the actual work of the project, you know, I'm clearly a clinician. I'm a nurse practitioner by education, and I do still take care of patients. So the workflow process is very important to me. I think working side by side with our engineers and our architects has been really amazing to be able to look at how we can design a room for the ease of flow. When we think about the most important thing to me about this project, and I believe I could speak on behalf of Newton Wellesley, is really about the patient experience is one. Patient safety, that is in today's world, and also around patient and staff responsiveness. How can we make sure we're being very responsive to our patients and really getting into the rooms and answering their questions and seeing them as best we can? Those are three things that are very important concepts around this project. I do think that we really wanted to look at having limited access as well, making sure that we are keeping our patients safe by using these pass-throughs from the hallway. We realized during surge that we really wanted to limit opening the doors, going in and out, and having that 6 feet space from the patient to the clinician and or the patient and the EVS worker or the food nutrition worker. We really thought we wanted to limit access to these patients in the room. So from a patient safety standpoint and also a staff standpoint. So working on these pass-throughs was, to me, before COVID surge, I really thought, I think it's very necessary. So these you know, ways to get into the room and how we actually deliver care have to be thought of in a very innovative way. And I think that the team has come up with some great designs around how we can limit the access. And the one thing that I do love about this project is thinking about voice activation so that we can avoid the touch of surfaces for patients that are in these rooms and also staff. I'll pause there for a second just to see if anybody has any questions, or if there's, Teresa, anything else you want me to focus on.
And I'm trying to show you guys on the screen that there's a pass-through. We're talking about exactly what's going to happen there, soiled and clean. We have talked about food, but that might not be the best way. And then we're also looking at 2 doors into the bathroom so the cleaning staff don't have to come into the room. So there's things like that that we're considering. But it's all still a conversation right now. And just as our last slide, so as Sandy talked about, we are talking about COVID and future emergencies and how we can respond to that, and along with the HAIO aspect, looking at clearances for 2 patients potentially. We're looking at all sorts of different systems and products. And you're not hearing it on the phone right now, but we have a really deep bench of code and mechanical people helping us out. And technology is becoming even more important. So thank you, everybody, for this. We wanted to showcase all the work that we've been doing since 2015. And I'm going
That's
to
fantastic.
turn it over to Stan now.
Great, thank you very much. And if the folks that are on this panel could turn on their sound and video, and the others go off sound and video, that would be fantastic. The second session for today is looking at mechanical systems of the future, and we have a panel of owners, Jason D'Antona from Mass General Brigham, Michael Kennedy from Tufts Medical Center, and Paul Cantrell from BI Leahy, and then also the design community, and I won't read those names, and the mechanical subcontractor, John Conestraro. So, and this is really meant to be these are very deep topics that we could go on for a long time, but we've got about 7 or 8 questions that we're going to move through fairly rapidly and give a really good overview. But just first starting with the owners, the changes to HVAC systems experienced to date, and that is what changes to facilities and engineering systems have you seen in the past months, and what do you think may or should become permanent changes for healthcare design? We'll start with the owners, and then we'll ask a similar question of the designers, what they're seeing. Jason, do you want to start with this question? Jason, you may be on mute.
Sorry about that. Yes.
There we go. Okay, great.
I didn't have my glasses on. Yeah, I mean, really quickly, I can summarize where we are to date. In the initial onset of COVID back in, I guess would be March through May. You know, the initial first wave caught us very, very quickly, and we had to kind of scale up operations throughout our facilities at a very, very rapid pace. Because of that, many of the local FMs were working independently with their local infection control teams, their local incident commanders, to implement measures. When the first wave subsided, towards the end of May, early June, we sat down. We had an opportunity to sit down with all the facilities, and we noted that some facilities were taking different approaches than others. So we formed a task group with myself and John and a whole host of folks from infection control, clinical operations, facility managers to kind of take a step back. At that time, we also had the benefit of revised guidance from both ASHRAE and CDC. From that second look, basically what we came to the conclusion is that this is primarily a droplet-based transmission disease, and that most of the HVAC systems, if not all, that were in place were set up to deal with droplet-based transmission. And except in extreme cases where AGPs were being performed in areas that weren't under negative pressure, there really weren't any need to make any changes to the HVAC systems. And in fact, some of the changes that were made under duress in the early phases of the pandemic were actually kind of counterproductive, because they disrupted some balance on some floor plates, and they actually caused maybe pressurization issues in other areas. So that's where we are right now. In terms of the future, you know, I don't think any of us know. There's still a lot more research that has to come out. There's papers coming out daily talking about the potential for aerosolization. I think there's been some guidance revisions that have come from the CDC, the World Health Organization, but there's still no quantifiable metrics in terms of what the HVAC system can do outside of a larger infection control regime and control the spread of the disease.
Great, thank you. Paul Cantrell, do you want to add anything to that from your experience with BI Leahy?
Sure. I think from looking across the system, you know, there's new hospitals, there's community hospitals, and I think everybody here understands the decisions that have been made over the years as to how things get value engineered out, which is usually the mechanical systems. This is where it's kind of highlighted, and certainly the community hospitals' lack of resiliency or flexibility in some of your systems that are behind the scenes. And to Jason's point, some of the institutions are actually working differently than other institutions. Some of the infection control wanted to go under negative pressure. That has its own complexities. But I can say that looking across the ambit, we actually did come up with some alternatives that we couldn't get past not turning a room into a negative pressure room. We were able to take some of the existing systems and go back into, let's say, the return air system. We would actually split that and actually have that exhaust on the roof where we could actually get access to it. But you know as well as I do, some of these other systems are so built into the infrastructure, and where you don't have the access to go ahead and get to an exhaust, it limits you to do that. There was other ways for us to combat it, which was to just recirc with a HEPA fan in the room, and I think many of those pieces are there. And certainly in the new designs, it needs to be considered in how are we going to do that. With this particular pandemic, it's a droplet based. We didn't know that coming out onto the scene. But I think we have to consider this, what it may be, if it is, let's say, something similar to a TB, where it comes back into the system and can travel a little bit easier. What is that going to be? And what's the resiliency that we're going to put into the infrastructure? I think that's what we have to kind of get to, is the resiliency of our support system. I mean, the environment of care is we provide the environment and they provide the care, but if we can't provide that environment with the mechanical systems, I think we're going to be faced with another challenge that we have not seen yet, but we should be preparing for. I have to go on for another half an hour just about this.
Thank you. Michael Kennedy, I am not sure if you're on the phone. If you are, if you'd like to add.
Yeah, I'm here, and
Great. Thank you. Great.
It's great. I mean, it's interesting because we've experienced the same things that both Paul and Jason have talked about in terms of, kind of the manipulation of the system and having it be counterproductive. We ran late into the spring where we had, taken rooms and messed with the balancing, and then we had, air conditioning issues, and it got hot, and people were in full bodysuits, and so we really ran the gamut in terms of reaction to the whims of what this kind of the whims of this organism, if you will. And I think that, to Paul's point, the sooner we can address the infrastructure issues going forward and have a little more flexibility in that, the better we'd be in being able to respond to this in the future.
Right.
We did do a lot of room measurements because room turnover, so that we were getting faster air exchanges, so that we could, again, we had people sitting in ED waiting to get in beds. We couldn't wait 2 hours for 12 exchanges, etc. So I think there's going to be, the sooner that we can get the infrastructure in place, the better off we'll be for the next time around.
Great, thank you. I'm going to ask if we could go to question number 2. This is ask the designers from their experience that they're seeing with designs, what design and code changes that you expect may come out of this pandemic, and what types of design options are being considered for more flexibility for systems in the future. And if Paul Condrat, who's on the ASHRAE 170 committee, and Alan Ames from BRSA could address this question, that would be great. Paul?
Sure. Well, one code change actually just came out, the 170 committee on October 30th. We released Addendum S to the ASHRAE 170 standard. And what Addendum S does is it took some of the more recent knowledge that we've gained through this pandemic, and it is now allowing airborne infectious isolation rooms to be tied into a general exhaust, assuming that you can run that exhaust through a HEPA filter first. The standard up until this point had been a bit more conservative about that particular aspect and always required a dedicated exhaust. So that was something that the committee, we discussed at length, had advisors from the NIH and the CDC involved in develop that addenda, and again, that was released just a little less than 2 weeks ago. As far as other changes that we're discussing within that committee, one of the things that we've known for quite a while is that ante-rooms in areas where you're trying to control infection are effective. So we're always weighing the minimum standard against the minimum standard as a code against what is the optimal performance. And then we're talking about other things that have been done. Again, as Jason and others had mentioned, there's a lot of research that's coming out that needs to inform what the future will be. But, do we need to start to think about, having planning for more official planning for surges, which might include pandemic modes, that kind of thing. There's a lot of discussion about that, but I wouldn't say any imminent code change coming out of the ASHRAE 170 committee other than what I just discussed.
Alan Ames, is there a...
Sure. I think Paul addressed part of the things I was going to discuss, but ante rooms and operating suites were one of the things that have been coming up a lot recently, because if you have a COVID patient that's in NOR, which is positively pressurized, it's hard to contain that. Haven't really advanced that a lot further. But that's one of the things. Airflow patterns in patient rooms has been a topic of discussion, and making sure that it doesn't increase the likelihood of transmitting the disease around. Things like the UV lighting as disinfection and increasing the filtration levels in the air handling units has been discussed, but usually the virus doesn't make it back to the air handling units, and increasing outside air percentages is another one that everybody's been looking at. I don't know that any of that's going to be codified and included, but certainly a lot of the healthcare providers are talking about all different options to increase the safety in the facilities. And overall, it would be humidity control is another one that's been a hot topic for a lot of owners, and looking at how they can increase the humidity levels in buildings. So there's a bunch of things out there. And one last thing is the medical gas systems and being able to hook up ventilators. We've looked at several systems out there, existing systems, trying to figure out if they could hook up 2 ventilators in a patient room in a surge mode as compared to 1. And most of the time, the piping systems aren't designed to support 2, but that's another thing that we're looking at. So I don't know, again, if they will make it into the FGA guidelines, but I'm sure that, or the ASHRAE 170 guidelines, but those are all things that are on the forefront right now.
Great. Thank you very much, Alan. The next question, Teresa, if you could move that forward, is I won't read the entire question, but the gist of it was weighing the costs and benefits of changes in design and how that's being assessed by firms. And actually, in the week before this conference, I reached out to a lot of healthcare hospital executives, and this was one of the questions that they came back with was, that cost benefit, and in the sense of the cost, but also environmental or any other types of environmental standpoint, maintenance, humidity, those aspects. So to address this, Sean Bryce and Michael Lorimore are going to speak to this, and certainly looking forward to that response. And thank you from the healthcare executives that responded with questions. This was an interesting one.
I'll start, if that's okay, Michael.
Thank you.
So we've been looking at what the infrastructure has been doing for both the existing systems and what could have actually been changed in the future, or you know, how would this help? And as we've been saying, you know, the pressurization is paramount to how you use the systems. And in many cases, changing pressurization in one room versus the other, one floor versus the other, one building versus another, if they're all connected together, can have a major disruption within the operations, not just within the ICU, but within the entire building. Cafeteria, you can go right down the list. So basically, we looked at 3 different paths on this. So the first one was do nothing, which is what I just described. You know, you just status quo, just the way it's running now, is the way it should run. People on ASHRAE 170, Paul, you know, you guys spend an awful lot of time going through and developing those standards. Those were not, you know, just off the cuff standards, and they work. So, you know, in its efficacy, you know, how well can you measure that it worked? You know, where'd the pathogens go? Did it actually filter it out? That's a whole other discussion that I'm not going to get into right now. But then the negative pressure rooms, you know, how much more energy do you need to do more negative pressure rooms or AII rooms for what you've got? We saw an awful lot of small incremental units that went in the windows that were HEPA filtered just to create a negative environment within one room versus the other. But what I'm now talking to owners about is not necessarily a negative pressure environment. It's what I call directional airflow. So it doesn't actually have a sensor that says, you know, I have 0.01 inches of static pressure, negative pressure from one room to the next. But to protect the clinicians, the air that goes into the corridor is then reused as it's going into the individual patient rooms. And that directional airflow discussion, I think, to the original question, minimizes or mitigates the amount of additional money that you're going to have to pay for consumption for what you've got. Then, you know, the other part of this is many of the buildings, and probably all of the buildings we're talking about right now, are either a high rise or close to it. And you know, high rise facilities, they should already have infrastructure to be able to convert to 100% outside air, albeit at a reduced airflow. Because when you actually test the fire alarm system, you can't just take people out of the ICU and test when it's 0 degrees outside. So you've already got heat. You should be able to get that, and then you can make a decision as to whether or not you want to upsize your chiller plant and do that thing. So there already are controls in place to just basically use if you want to change what is going on. And I'm not suggesting that everybody does that. We did have one facility where we converted to an exhaust system from a return system, and that was a design that was put in over 10 years ago, and believe it or not, it worked. But really didn't add additional air or airflow to it. It was just, instead of bringing the air back to the air handling equipment, it just dumped it outside instead of bringing it back like you normally do. So, you know, I guess the end of it is there should be a significant amount of infrastructure that's already in your buildings to either use or use in a different way. You already have a defend in place system, so that you've got to have some kind of heating and cooling that's there. And Paul, do you? I don't know. Maybe we put another column in the 170 that says, you know, which way the air goes instead of just the pressurization. What's there? Thanks.
Michael, is there further that you'd like to add to this discussion?
Yeah, just to add briefly to what Sean said and what everyone else has said as well. I mean, I think, you know, definitely in looking at this, I spoke to, you know, my colleagues on the West Coast and, you know, around the world as well. The difference, you know, in the changes is, as Sean was saying, about the short term, you know, what we can do with what we already have, and then, you know, into the long term, you know, planning for the future, again, that was sort of talked about by Jason as well. And I think that, you know, the short term measures around enhanced air change rates or extra filtration that have been talked about and tried, you know, in the air balance, you know, they have had some success, have had some issues, some consequential issues that I think, you know, have been talked about, which is really, you know, interesting to hear. And they also, you know, they generally, you know, will incur lower capital costs, but perhaps higher operating costs. So in terms of weighing up the benefits of them, you know, they can be done quicker, but, you know, they kind of don't necessarily have, you know, the long-term thought going into them. You're running the fans harder and longer, you know, and so not necessarily in systems that were designed for that, you know, at the outset. Whereas, you know, the longer-term planning around the infrastructure, and it's, you know, really interesting to hear that, you know, there's a recognition that the infrastructure does need upgrading, you know, in many of our facilities, to make sure that they are designed, you know, for all of these issues, you know, to be considered in place around air movement. So, you know, as Sean was saying, it's not just about air change rates or pressurization, it's about air movement within the spaces, to create the right air quality, and also air monitoring as well, to sort of understand what's happening, you know, in there. But no, I think, you know, there are lots of things, you know, that can be done, you know, and I think, you know, we need to sort of just keep learning from the lessons that, you know, the hospitals are feeding back to us, and making sure that, you know, for future surges, that we have the best systems in place for that.
Great, thank you. Teresa, if you could go to the next question. This is regarding, this one came, there were a few questions that came back to me on emerging technologies, and that is what is promising, but also how are people assessing these options and for themselves and for their clients. And I want to first ask John Conestraro and then Paul Condrat on this question about emergency technologies. John, if you'd like to, and then we'll ask the owners what how they're assessing the information in the marketplace. But John, if you'd like to speak to this.
Sure, Stan, thank you.
Thank you.
We talked about it a little earlier on the call, back to the roots, and the emerging technologies are in fact technologies that have been around for quite some time, whether it's the UVC lighting, which has been around for, I think, almost a half a century anyway, more, and just so and controls. There's a tremendous amount of controls required for patient rooms now in the future, as far as having them be able to go into full exhaust mode and all of that, and keeping all the pressure differentials throughout the floor of a hospital. So I think the technologies are there. The use of the technologies and the training on how to use all of these tools is what is probably what will be emerging more need for training in keeping in these systems. I don't have anything that's too specific as to a technology that we're using right now that's brand new, because most of the projects that we're looking at now are for retrofitting existing, and the existing facilities are grossly, you know, they're not adequate to handle any of the new requirements for outside air changes, etc., cooling. And hospitals are okay, but more in other facilities, schools in particular, are not quite designed for this use.
It's a great point about the training and the understanding of the capabilities of the systems that you, in some with controls and whatnot. That's great. Paul, would you like to add to this?
Sure. So there's some interesting research that's been done regarding ventilated headboards. I can share a link with the group that Kaiser Permanente did on the West Coast, and Travis English, who's the director of engineering there, did a nice presentation on that, which shows just a different way of capturing airborne contaminants around a bed. It's not not a new idea, but gaining traction because of, you know, recent events. There's been a lot of discussion in the marketplace about bipolar ionization. That's a technology that is needs some more research, and every manufacturer is a bit different. So the jury is sort of out in the design community as to its efficacy in the healthcare environment. The American Journal of Infection Control a couple months ago published a great article on the use of the UV light robots for cleaning rooms, which actually showed a 16% reduction in HAIs when they applied it in the way that they did, which didn't add time into room turnover. And then another application that we've been researching comes in the MOB context. You know, we're battling, you know, patients are going to be going to their doctor's offices and potentially be infections. And these buildings were never really designed to handle that. So the use of like a fan filter unit, but thinking of it being used in reverse, you know, a lot of those older buildings are plenum returns, and right now any infectious agent would be going up into the plenum and gone through the building. With the addition of a simple fan filter unit, you could at least put a exam room under a directional airflow, as Sean was explaining earlier, and HEPA filter that before it gets up into the plenum. So it's not perfect, but it's much better. So those are just some things that we've seen kind of interest in more specific technology.
Great. For any of the three owners, if there's something you'd like to add on how assessing of the information in the marketplace, you could speak briefly about this one, and then I want to move on to the next question.
I think for us, I mean, I think assessing it has been, everything is very careful right now. Again, you have to balance efficacy, cost, efficiency with some of these things. We have instituted ventilated headboards. Becomes really important when you look at the different acuities of patients. You know, if you look at a HEMOC unit where really their care requires positive pressure to protect the patient, yet maybe they're presenting as a PUI and need, you know, you need to protect the healthcare provider in that process in terms of creating a negative pressure. So the negative headboards or those headboards are something we've manufactured in-house. We're using with, you know, regular 500 CFM portable HEPA units and you know, creating that environment for staff. And then the other couple of things that we've looked at are the Viavito antimicrobial lighting, which is not a UV lighting, but is antimicrobial and stays present all the time, specifically for public restrooms, things of that nature where you just can't have housekeeping touch it enough. So it provides a certain level of kill claim there. And then the other piece is ULPA filtration in terms of when you're actually cleaning a room, is using vacuums that provide ULPA filtration so that the filtration process is greater than what the HEPA filtration process is taking. So you're not regenerating, you know, the dust or any of the organisms from the patient room into a clean environment outside of the room.
Great. Any of the other owners want to comment on this one? The next question is for the owners as well. So
the only thing I can actually add is, I'm sorry, this is Paul. The only other thing I would add is actually to look at far UV, but there is a struggle trying to figure out cost, whether it's a new gimmick that's coming online and trying to vet that through. But one of the other pieces was instituting far UV, which is a much higher kill rate than regular UV light. It's supposedly a single pass, 99.9% kill rate. But it is a struggle trying to find out or to get past the gimmicky thing and commercializing. So at this point, we just haven't figured out what's been on the market long enough from these other pieces of equipment that are coming on board.
Great. Thank you. We have about 6 minutes left, and we're certainly willing to go over if we need to, but I do want to get to the next questions. And Teresa, if I think you need to move down 2 questions to this. When I solicited questions from the hospital executives, I got a couple of questions back on operations and maintenance and protection of the staff. And I just wanted to ask the three owners about this, and then ask the designers and John Canestraro about some of their considerations on this. But so the owners, what types of administrative controls, policies, and we talked about training before, should be considered for this new norm, and what types of precautions are you really focusing on? Jason or Paul, if you want to start.
Sure, Stan. So after the first surge, our infection control teams got together across Mass General Brigham and issued what was called an infection control blueprint. And that put into place a lot of policies and procedures for access to space, for PPE, procedural requirements. We then took that with our facilities task force, and we put together our policies in terms of operations and maintenance of the spaces, including any temporary measures if employed, any permanent measures, any system changes, access, and maintenance. This standard was essentially a stopgap standard until larger ongoing new construction standards could be deployed, and we're expecting to have those available in probably at least draft form by the end of the first quarter of 2021. The important thing to note is that any of our operations, and in terms of how we deal with our systems, whether it be HVAC or our med gas, or even maintenance, is closely dovetailed to the infection control policies. And I think that's the key here. And like I said in the onset, that things weren't as coordinated. And in this pandemic mode, where we're dealing with large volumes of patients who may or may not be infected,
considered in the designs, or for your subcontractor workers on the job site. John, would anyone like to address that? Perhaps John, you first.
Well, coming back from the pandemic, the construction industry was very, very, very calm and safe. There was a lot of, sequencing of the work was done in such a way to enable more social distancing, especially in elevators, break rooms, and meeting rooms. But now we've come into a little bit of, as an industry, a little bit of a softening of the attitude, and there's a spike. We're experiencing spikes on projects. And so as a company, we have tremendous safety concerns, mandatory mask policy, for example, that we just instituted, with a policy of subject to termination, but also about being sent home to start. It's hard because everybody's working and they have to work. So it's we take it very, very seriously. As far as servicing in an existing hospital, obviously the protocol that the hospitals have instituted for the infectious disease control is all of our service folks would definitely follow that. And but it is a very important concern.
We're at the end of the hour. I would like to just take a minute and ask the same question to the designers, but for those that do need to leave, thank you very much for your time, and we really appreciate the hard work that everybody is doing in this during these extraordinary circumstances, and we look forward to. I think we even have a date for the next session, is January 12th. We will send out a notice on that soon to hold that time for people, and are developing the agenda for that meeting. So thank you very much, everybody. I am curious on this last question, if people do have a few more minutes, if there's one of the designers would like to address this, what they're seeing for considerations in their design process.
So
Paul?
I guess I'll chime in. The you know, the magic miracle cure to a lot of this is HEPA filtration, right? But somebody has to change those filters. And so making sure that you're designing the systems that you're adding those to in a way that is easy to do, so you're minimizing occupant time. I mean, most healthcare organizations are pretty good about their operations staff using the appropriate PPE when they're changing something of that nature. It's easy on an exhaust side. We can do bag in, bag out housings that help reduce that exposure. However, you know, when you're talking about HEPA filters and recirculation units and that kind of thing, being able to take into consideration the personnel that have to change those filters, and just making sure that it's easy to do, much in the same way that Teresa's presentation was about minimizing infection control to patients through easier cleaning. Same kind of thought process goes into that.
Anyone else have anything to add to that piece?
Yeah, this is Alan. You know, some of the things we see are the older facilities that might have fan coils in rooms and things, and those are a lot more difficult to kind of take care of. And we have not seen a good response other than, you know, basically shutting it down and decontaminating it, shutting down the room and decontaminating it. But that is one of the safety concerns of, you know, we hear from the facilities engineering staff about what they should be doing in order to make sure that it doesn't replicate and, you know, everything is done properly. But again, that's you know, something that each facility has to take a look at.
Well, thank you very much. Anyone else have anything to add on that? Well, again, I appreciate everyone's time and ability to, or willingness to share ideas in this collaborative format in both this panel and panel number 1. And fascinating discussion. Again, this is recorded, and we will post that within the next couple days so that people can reference this as they need to. And I think 1 or 2 links were discussed today as possible resources. So we will also distribute those when with that distribution of the recording. So thank you very much. Any last thoughts, Teresa?
John.
Could I
just please?
I prepared a moment for talking about you know, installation, because I think throughout,
thank you,
Paul, there's a very change in design. The patient room of the future is now becoming the clean room of the future, and with the vestibule design and with the negative pressure of a patient room, there's double the amount of ductwork going into the ceiling in some cases, especially in the new hospital designs. And all this ductwork needs to be accessible, all the filters and all of that. And I think it's important for the design community to look and see what we have for floor-to-floor heights. Also look at what partitions are going up all the way to the deck, and coordinating that with the structure, so that when we go in fireproofing, especially for all those wall penetrations, because we may have a lot more wall penetrations because there'll be more walls going up to the deck, things of that nature, and that needs to be really ferreted out. It's a lot of details much more details. The other thing would be the cost. Everybody's you know, we're all concerned with safety first, quality, cost. And to really have a value target design up front I think is very, very important. And having installers look at that, and there'll be more MEP coordination up front too. So I think that's how our industry will change as far as from the eyes of an installer when these new hospitals begin design development. And what things, there'll be mechanical systems and how they'll change. That's not what I want to add. Thank you.
Thank you very much, John. Great. With that, Teresa or Richard, if you have any final remarks.
I just want to
Just
thank
thank you.
everybody for freely sharing their ideas. It's really in the spirit of HIO, and always appreciate everybody returning my calls and emails so quickly. That's really great. Thank you so much.
Richard.
Thank you very much to all. Thank you, and especially Stan and Teresa for all your efforts.
Great. Thank you,
Have a
everybody.
nice day.
Okay.
Thank you.
Thank you.
Have a good day.
Thanks.
Bye-bye.